joining us this morning, and we'd like to start by introducing you to Calvin, pictured here. Calvin lives in Tanzania, and 5 years ago, when Calvin was only 9 years old, he started exhibiting these very strange symptoms. He had a very high fever that never seemed to break, and he started growing a lesion on his scalp. The local doctors could not figure out what was causing these symptoms, and even after surgically removing the lesion, his condition did not improve. Eventually, Calvin was referred to Muhimbili National Hospital in Dar es Salaam, and he was diagnosed with leukemia. But I'm very happy to say that Calvin is now 14 years old. He's studying in school and he has the dream of becoming a doctor one day, and he is 100% cancer-free. Calvin would most likely not have survived had it not been for the dedication of a consortium of international and Tanzanian health workers, NGOs, and local parents and supporters who have decided to make the cause of children's cancer their own. And this consortium has now blossomed into our organization, Tumaini la Maisha, which means hope for life in Swahili. And Tumaini is the first and only NGO dedicated to improving the well-being of children with cancer in Tanzania. And in less than 10 years, we've actually made significant progress in improving the treatment of cancer for children in Tanzania. Back in 2005, we were only referring 100 children to the cancer ward, and now we are treating over 500 children annually. And part of this is due to the expansion of our cancer ward. Originally, we only had 17 beds, and now we have 50, so we've more than doubled our capacity. And through this improvement in our infrastructure and this increase in capacity, we have been able to increase the childhood cancer survival rate in Tanzania from only 12% to 60%.
So how did we do this? How were we able to make such a substantial impact over such a short period of time? So luckily we were very encouraged by the Tanzanian government and very backed with their support that they have prioritized pediatric oncology as one of their main health concerns within the country. So with their support, we've been really able to start establishing a really holistic method of treatment for all the patients within our ward. So this includes psychosocial support like nutrition programs and play therapy for the patients, as well as support for their caregivers with money management workshops, as well as counseling services for them while their children are undergoing these treatments. We've also established a number of clinical educational programs, which we'll talk more about later, but one including a master's education program to really encourage increasing the healthcare workforce within the country. All of this while focusing on expansion of the facilities within our cancer ward so that we're able to treat the greatest number of patients possible. However, there's still 2,500 new pediatric cancer cases each year, and many of which are curable if they were in the Western world. So there remains a lot to be done so that we can further improve. Okay. Yeah. So although we've made progress, there remains much to be done.
To address this need and to reduce the amount of time necessary to gain access to pediatric oncology services in Tanzania, MNH Muhimbili National Hospital will collaborate with 2 other university hospitals in northern and northeastern part of Tanzania. And these 2 hospitals are KCMC and Ganda Hospital, as you see here on the back. Our 5-year plan aims to set up pediatric oncology services in each of these 2 hospitals. Both of these hospitals are currently collaborating with universities in the United States, in addition to having clinical and non-clinical resources in place to sustain further program expansion. To successfully implement the expansion, we need to adopt a holistic, comprehensive approach that will focus on 4 major aspects of pediatric cancer diagnosis and treatment. These components include non-clinical and psychosocial support for our cancer patients, their families, and caregivers. Furthermore, we are going to need provision of drugs and other clinical resources for our patients, short-term and long-term training of healthcare professionals that will focus on pediatric oncology, and finally, outreach to community and first-line healthcare professionals. We do know that in order to provide best possible cancer treatment for children, it is absolutely necessary to gain a holistic approach to cancer treatment. We realize that the adequate nutrition is fundamental to helping the children's body fight cancer back. Therefore, we'll expand our supplementary nutrition program that we already have in MNH by equipping a kitchen, hiring a nutrition specialist, and providing weekly supply of vegetables and fruits to our patients, both in KCMC and Uganda hospitals. In addition, our play program, which is structured by a play specialist and led by 2 local teachers and assistants, will provide a certain level of normality and fun in the children's lives, and will also provide a way to sort of a break from the medical reality that the children unfortunately have to live in. The school program will cover topics such as mathematics, literacy, arts, crafts, different projects, and ensure that the children's schooling is not significantly interrupted by the hard treatment protocol that they have to adhere to. As part of our social support program, we will have buses that will transport patients who cannot afford to reach KCMC and Buganda hospitals. The bus will service premises in proximity to each hospital to transport not only regional pediatric patients, but other patients who are treated in KCMC and Buganda. Finally, our outpatient and family housing program will provide a home away from home for children, their families, and their carers. Meals and lodging, in addition to counseling, will be provided to outpatients, their carers, and family members as well.
Okay, so one of the essential components of clinical care is a steady supply of drugs. And while most of the standard clinical supplies is readily available in Tanzania, a lot of the medications that are more specific to cancer treatment are not as easily accessible. And right now we're procuring our drugs through a variety of different avenues. So as part of this program, we are going to pool that procurement into a single system. And by having this one unified system, we'll be in a better position to negotiate with drug suppliers. And this will ensure that we establish reliable partnerships and that we have the steady supply of the drugs that we need for this treatment. We'll also be establishing a data management system which will be housed at Muhimbili Hospital. And through collecting this data, we'll be able to standardize the treatment across the country and also continue monitoring the quality of care. Another essential component of clinical care is the education of specialists in pediatric oncology. Right now, there is only one pediatric oncologist in the entire country, so there is a dire need to train more people with this expertise. As mentioned before, we have already started a master's program in pediatric oncology, and we have 2 students currently enrolled. They'll be graduating later this year, and they'll have the skills they need to begin treating patients. We'll also be establishing a certificate program catered specifically for nurses who will help in the cancer wards. And this will be more of a modular program that the nurses will be able to take at their own pace. And we wanted to give them a more flexible program so that they can continue working while studying and begin applying the principles they learn while they're treating our patients. The third program we're developing is a training program for lab scientists who can assist with conducting biopsy reports. Right now, the biopsies are actually being sent to Ireland, and as you can imagine, that takes a lot of time and delays treatment, so it's really important for us to have these specialists trained who can conduct the biopsies within the country. And last but not least, we are also working with Muhimbili University and the Tanzanian government to establish an MD program to train the first in-country pediatric pathologist. And through these educational programs, we'll be able to ensure not only the growth, but also the sustainability of children's cancer treatment within Tanzania.
And lastly, we really want to emphasize the outreach component within our 5-year plan. So one of the main reasons why these children have such high mortality rates is because their caregivers fail to recognize the early symptoms and it results in late diagnosis. Or the first-line health provider is unaware of the services that are available to them within our clinics. So we really want to address both of these issues. First, with the first-line health provider outreach program, we really want to tie the link between our clinics and then their offices so that they know that if a patient comes in and presents these symptoms, that they know to come to our clinic and to refer them to us. By increasing the number of referrals, we'll be able to treat them sooner and then increase their chances of survival. We also really want to emphasize community-based awareness workshops because a lot of the common cancers present visual symptoms that anyone can recognize with the human eye. So we really want them to be able to do so and then get the help that they need as soon as possible. So through these programs, we really want to increase early diagnosis and thus increase the survival rates of childhood cancers within the country.
Okay, so we have designed a 5-year plan that incorporates all the elements just discussed. And we have estimated that for over the 5 years, for all the components, it will take close to 8 million euros. And the reason why we use euros instead of dollars is because the majority of our partners are actually based in Ireland. So we wanted to standardize it for that sake. And the majority of that will go to clinical care. And within our proposal, we do have a very detailed line item of all the different costs. And we divided it up into the different components, and we did so that our donors could look at the program and see what components cater to their individual interests. And we believe that by doing that, any amount will help, whether that goes to drug procurement or to the training of specialists or to play therapy. It's going to bring us one step closer to achieving our ultimate goal.
So my colleagues have told you of the very comprehensive plan that we have in our proposal, and no doubt you have questions saying, is this really possible? Can they do this? These are legitimate questions. And also, how sustainable is this program going to be? So I would like to convince you that we have actually presented to you a program we've already got implemented in all the components. We have tested it, we've worked out the kinks, and now we're ready to invite other people to join us in partnering to ensure that we meet our vision of giving care to all of these patients. So you could also then say, you've only tried it in one setting. Perhaps, there are partnerships that always engender more problems into more issues. We've actually spent the last 2 years working with our partners who are equally big hospitals, and therefore have their own ideas of how things can be done. We've worked through everything with them, and we've decided that there is no one partner that's bigger than the other. We decided that we all come under the umbrella of Tumaini, and therefore we would work together, but still maintain the autonomy of our different organizations. There are main components that we can do together, and we've also already discussed with you the procurement for drugs. That strengthens us. They strengthen numbers, and we will do that. Education will also be done through one of our facilities, and not everybody is going to be training a single physician or anybody. They need training to make sure that we achieve this program. In addition, therefore we have had clear agreements about how to move forward with this. All stakeholders share this vision, as I mentioned, and it can really be replicated. So our answer to the first question is a resounding yes, we can do this. It is feasible. The second issue is the sustainability. We've also built sustainability into every stage of the program, even as we're building it. We've had 8 years to do this. We started from scratch, and we knew that we really needed to ensure that there's a sustainable program. So we've taken time, created an MSc program, and we have actually been in collaboration and discussions with other institutions all over the world to partner with us in ensuring that we can train all of these individuals within Tanzania, people who are committed, and we have also given them a clear path for career advancement. So we believe that this will be sustainable, and within a few years, we hope to transition away from having external people coming to train people, because in about 7 to 10 years, the graduates of our program, we assume and expect will be able to themselves to be the trainers in this program. It will be a gradual transition, but we're certain that we can achieve this. So, the children of any community are really the treasure and the future of the countries. The children in Tanzania, really we believe, should have access to the same degree of quality care that has existed in the rest of the world for several decades. we have worked very hard to try and ensure that this happens. And so we have a vision. We all embrace that vision that we will do this successfully. We invite you to please join us and support us in our goal to ensure that children in Tanzania get access to the free, high-quality care that they deserve. Thank you very much.
Okay, that was terrific. I thought when I read the scope of work, I had some questions about actually what TLA was asking you to do, and you may have similar questions. So just in turn, let me make sure I understand how you were taking the project here, the task. I guess as you've interpreted it was really to craft a national plan based on the work that's currently going on at the 3 hospitals that are most involved in that. Is that a fair statement? What is it that you were, could you give me the sentence again, the 2-sentence elevator speech about what you're trying to present here? Is it, well, I should ask you.
Yes. So what we're presenting is really an expansion of what currently has been demonstrated to be successful in one institution. The next step is to expand this to ensure that children all over Tanzania do not have to travel long distances to get to one hospital in Dar es Salaam. So strategically, we partner with big institutions that are in the northeast and the northwest part of the country. These are well-established institutions, but do not currently have a pediatric oncology care.
Right. So you're trying to take the program, which, as you've said, you've got demonstrated success in, and scale it on a national basis. Okay. And one question a funder might have, you can't sort of look at one area and say this is more important than another. It is the fact that I couldn't find statistics for the country, but worldwide only less than 10% of under 5 mortality comes from non-communicable diseases. Are there elements, and you're talking about, what was the number, 500 current beds, was that something along those lines, and there are 20 million, 25 million children in Tanzania. Are there elements of this, and there may not be, but are there elements in this program that could be exemplars or pillars for strengthening the hospital system in general, or should I just think about this as it's a problem, it's very important, if you or your loved ones have cancer, there's nothing more important. How should I think about this?
Yes, and that's a very good question, but if we think about what care really is required to implement comprehensive care for cancer patients, by that itself, it suggests that you have to have a lab test, basic lab test. So once you establish that, you're actually ensuring that you establish it for the whole system. It's not just about, so taxing the system enough to ensure that those things can be delivered will make sure that everything else rises to a minimal level for other patients. So inherent in providing cancer care in this sector is actually taking a level of sophistication of care delivery.
Right, because there were 2 elements in this that I wasn't sure how you were going to approach and that you might think about as part of the pitch, as it were, in general. One is this is not just about this, it's a pillar, it's an exemplar, because it's a demonstrable success story, at least as far as it's been applied so far. Put aside the difficulties of scaling, but it's very successful, so it could be an exemplar for strengthening the hospital system in general. Another approach, which is different, is that the Ministry of Health is juggling a welter of priorities, and it could be that, look, funders in the country and Ministry of Health, you've got to prioritize things. You should prioritize this because we're very good at it, and on a cost-effective basis, I can demonstrate that you can make the following progress. At least for me, if there were elements of either of those, putting that into the presentation would have been interesting.
You want me to go next? Would you go last? You can tie it all together. All right. So first, I thought you did a really nice.
He's chomping at the bit.
No, I thought you did you did a really nice job. I thought you had great presence. You were confident. You demonstrated you understood the situation. I loved the Coleman story at the beginning. That was lovely and well done. And something that we had said to the other group about making it real life, you did that. And you know, you saw his smiling face, and it couldn't help but bring you into the presentation at the beginning. So well done. I think I want to comment a little bit, just elaborate on what John said, and that is, this feels very broad. So if I'm a potential donor, you've come to me with an a la carte, and I get to choose from the menu which thing I would like to buy.
The food thing is coming.
The food thing, yeah, I'm the food guy. So you come to me with an a la carte, and as a donor, generally, I have a focus, and so it's kind of hard for me to zero in on where, you know, until I got to the piece that intrigued me, where I would fit into this. So I raise that with you as you're going to potential donors. And to some degree, the challenge that they've given you seemingly is to boil the ocean. I mean, you know, on one hand, it's very noble that it's working, and I think maybe you could, at the beginning, demonstrate a little harder that it is working and that you're trying to scale it. And that would have been right up front, you might have said that. But they've asked you to do so much that maybe suggesting to them that you narrow cast this just a little, so that when you go to potential donors, you'll have more impact. It's just a thought. I may not be right on that.
He's right.
Success metrics, again, the same thing we said to the other group, critically important to any donor to understand exactly how we're going to know if their money is actually making an impact. And to say, I think one way to do that, I love the notion that you've gone from 12% to 60% of kids. So your goal, I would hope, would be to get 100%. And you may not be able to achieve it overnight, but that's what you're striving for, so that every child survives. And I'm going to turn it to Lynn. I thought you did a nice job, and I think you probably had a very tough assignment.
So I will start off again saying each of you did a great job with your portion of the presentation. And I think all three of us agree, and we actually even said something a little bit earlier on, looking at what you were tasked to do, it was, the breadth and scope was really extraordinary. And I do agree that part of this can be working with the organization to say, we need to hone this down in order to, because, you know, kind of when you go from training doctors in pathology to a play group to we're going to eat well to we have a shuttle bus that's going to take you there, it all sounds really good, but it doesn't really hang together from a, we need funding for this. You know, this is what we're going to work on. Even if you look at it from a prioritization, this is what we're starting with, these are the metrics, and you may have this in your report, these are the metrics we're going to be looking at the end of year one. Year two, we will start on this, these are the metrics we'll be looking at that point, and getting it a little bit more honed down, even if you're going to include all of these things. As it's presented now, it does seem just daunting to get your arms around it. I also loved the story of Kelvin. I would I would also say you need to know that there's a lot of controversy around cancer centers in sub-Saharan Africa. And, you know, is that appropriate funding when children are dying of diarrhea? So you know this is, you will hear this from people, and it'll be, I think the number of people is kind of small compared to it. I still think it's extraordinarily important we address it, but I think you need to have, you know, work on the construct of why this is important, and I love the idea that improving one part of the system raises the whole level of the system. And as we talk about getting to 100%, which I think should always be the goal, you know, striving perfection, we know perfection isn't possible, but if you're striving for perfection, you're going to get to excellence. And I think that's what we're really looking for in this is excellent. I will say the executive summary was not as good as your presentation. The executive summary I found a little bit difficult to sort of figure out what are we doing here. And we started off with Burkitt's lymphoma, then we went to all cancers, and so it was just a little bit, and then we went to all cancers, and then we went to bus drivers. You know, so it was a little bit, I'm being a little, and I don't, but I think the executive summary, again, probably like what we're all saying, you guys had, I think, the toughest one. I mean, so I want to be very clear about that, and so I think I will just, I would also say you need to discuss the brain drain issue of training oncologists and people who are cancer experts and making sure that they will stay in the country. That's another piece of this. So I know I'm now being a little all over the place, but I do want to say, I think taking an incredibly I've been doing this kind of stuff for a long time, and if somebody had given me this task to get done in 9 days, I would have had to get it in bed and pull covers over my head, you know, so I'm really proud of you all for tackling this and doing it as cogently as you did. So thank you.
Just to come back once more to this theme about the breadth that you were given and why you might want to try and convince your client to shrink it a bit, but to the extent you're discussing a national scaling plan, there are lots of tricky issues about scaling. Also, at some point, I mean, probably in the written materials, but from a presentational point of view, some nationwide, some sense of the ecosystem that you're operating in the country. If I'm a funder, I'm going to want to know, is Tanzania hospitable to this? Or what's the climate there? I don't mean the rainfall, but the approach to
But
this.
that may be important too for access to the hospital.
Absolutely. I mean, I looked up, just out of curiosity, the under 5 mortality rates for Tanzania have decreased markedly over 20 years. It went from like 191 out of 100,000 to 81 out of 100,000 in 20. Something very positive is going on in Tanzania. That sort of fact is something that, as a funder, I would want to understand and expect you to comment on. And it may be there's a lot of progress being made, but not in this area. It may be the country is clearly ripe for this type of national scaling because they've done X, Y, and Z already. But again, you're grappling with and grappled successfully with an extremely broad mandate here. But in that sense, when you're talking about national scaling, you've got to talk about the nation you're scaling a little bit.
I want to underscore something Lynn said, because I thought it was brilliant, and I would do it. If your client won't let you focus down on just 1 or 2 key imperatives, then I thought her suggestion was right on the money, which is stair-step it. Do the, you know, in the first year, it's a 5-year program. In the first year, here's what we're going to do, and here are the metrics. And then the second year, here's what we're attempting to do. And you're not going to be able to do everything all at once. And so if I'm a donor, I think her suggestion was excellent. That's the way I like it.
Bravo.